Good evening. I'm Ian McCafferty, President of BSIR, and welcome to this evening's webinar on saving an AV fistula, how to restore the flow. We're really keen that you interact with us, and so please use the question and answer tab on the right-hand side, and we'll try and answer them during the webinar. So, without further ado, I'd like to introduce Bella Hassan, who is a consultant interventional radiologist at Preston Hospital, for the first talk. Thank you, Bella.
Thank you. Thank you very much for joining me this evening on saving AVF fistulas and how to restore blood flow. This is Penumbra and BSIR educational event. The aim of the talk will be to briefly discuss the AVF service we have set up here in Preston, go through the causes of thrombosis within the AVF fistula, specifically look at the management using the Indigo system, also touch up on the new changes that you may have already seen or about to see to the Indigo kit and the Indigo pump. I'll show you a case example, and I will summarize some key take-home notes. The teams involved in the management or actually seeing thrombosed fistula are the patient himself, who may directly or indirectly report that their fistula thrill is absent. Dialysis nurses, and I would say they're probably the most crucial people because they tend to see the patients more often than anybody else. The renal or nephrology team, depending on your setup of who takes care of these patients and the name terminology used. AVF creation team. In our trust, it's the vascular surgical team that creates them, but I know in other places it may be the plastic surgeons, or they may now be done via an endovascular technique through endovascular surgeons or endovascular IRs. In my trust, the IR nurses and IR consultants are involved in a 24-48 hour service dealing with the thrombosis. And then you also have the IR radiographers who will be involved in the screening and the fluoroscopy part. In some centers, I know that some of the radiographers have been trained to do the ultrasounds as well, in which case, obviously, they will be a key point of the team. Renal MDTs, we hold one once a month. I think that's the minimum that you could probably get away with and having an efficient service. But obviously it'll depend on the patient population you serve and the way the job plans and the rotas and etc. work. Stenosis is probably the most common cause of thrombosis, and the stenosis can be primary, as in it's already there, secondary to the injuries that may have happened at the AVF creation, or there may be with time, which are the most common, that they appear with time, and it can be due to needling sites, needle injury from the dialysis needle, or because of turbulence, mismatch compliance of how the graft plumbing is designed, or a combination of different factors. I've also put down uremia because I know there's been a lot of research into that to say that uremia levels are also associated with new intimal hyperplasia leading to stenosis in these AVF fistulas. Systemic problems can include poor cardiac output, sepsis, diabetes, clotting abnormalities. All these can also lead to thrombosis, but it remains as a primary point that the endothelial injury is probably the most common cause of stenosis leading to the failed fistula. How to handle a patient with thrombosis. Usually you will get a referral, and maybe that you have a service where it's a direct patient referral, or it may be through your dialysis nurses who may pick it up when the patient's having a dialysis session, or the patient may have self-referred to them. It may be that the readings have been going off for some time, and this is obviously the result. Diagnosis comes from clinical history, ultrasound, Doppler, and fistulogram. It could be a combination of one or two, but usually you need to have some form of imaging to confirm that it's definitely clotted, and usually you have an idea of whether it's fresh clot. With fistulas, the majority of clot tends to be fresh and acute. There might be chronic near the wall, but essentially the majority of it would be fresh. Otherwise, you would have been informed sooner with their failed dialysis sessions. For the sake of this talk, we will go into treatment using the Indigo system, but it's essential that you treat the underlying stenosis. We usually dialyze most of our patients after fistula salvage, and I would highly recommend this if you're able to access that service and if everything's within one hub. Follow-up. This can be done either in IR clinics or in ultrasound sessions where you follow up with Doppler ultrasound, but also just have that feedback, a rapport with the patient of how the treatment went and what you can in future improve. So previously, the Indigo system was a large white pump and multiple tubings and an on and off switch. The new system is much more slick in the sense that the tubing is one single tube. The canister is already embedded within the kit, and you just plug the tubing singly, as opposed to the previous diagram where I showed you there was two kind of tubing to think about. What's special about this? It's to do with the new on and off switch. It's a dynamic flow switch, so it slides over the tubing rather than creating almost like a breaking point between one tube and the other, which reduces the aspiration power. So the more connections or more steps you have from the pump to the catheter tip, the more you're likely to reduce the aspiration power. So it's quite simple. You just press the on button and you would connect your tubing, as you can see here, and then you would set up to whatever catheter you want to use. Obviously, you would never have free flow running like this, but this is for the sake of demonstration to show you that there is a filter there which captures the clot, so you have an idea of what you're aspirating out. There's also been some enhancement and changes to the catheters. There's improvement to the catheter tips, in particular the Cat 8, where it's slightly more angled, so you have more flexibility in trying to aspirate the clot from all of the wall surrounding, especially aneurysmal segments. The Cat 6, which is the slightly smaller catheter, has also been improved with a stronger tip and an introducer to prevent that tip from any damage during the introduction into the sheath. The Cat D is probably the best catheter for fistula management. It's the shortest of the lot, 50 centimeters. And again, it goes with the idea of the shorter the connections, the closer you are to the aspiration pump, the more aspiration power you're going to have, the quicker the job, the more clot you're going to aspirate. And it's an 8 French catheter, so you'll need 8 French sheath, but it's shorter, so 50 centimeters, which is ideal for fistula management. You're still able to access through a jugular approach, is sufficiently long enough to do that, or directly puncturing through the fistula. And this is the new packaging, so everything is all in one box. This is just to show you that the clot has been coated with contrast to give you an idea of how the catheters just slide through and they aspirate. For a lot of the fistula work, we tend to use the separator and not the catheter alone, but you can do that in some cases. The advantages of having the Indigo system is because of the neurotechnology. It's atraumatic, and as we mentioned before, you want to reduce as much of the trauma as possible to prevent or prolong the restenosis phase. It is the highest aspirating catheter out in the market, and you can use it for multiple pathologies or areas where there's clot, not necessarily just the fistula. You've got a wide range of sizes and lengths to deal with the pathology, and also you don't need to use lysis, hopefully preventing overnight stay, and it's not reliant on potassium levels. This is just to show you a case of a lady that had a stenosis that'd been there for a long time, and we think is probably related to an injury at the AVF creation time. She'd had multiple stenotic lesions, and she's had multiple angioplasties, one of which ended up with a perforation, and she needed a stent. She presented to the dialysis nurses with an absent thrill 24 hours after her previous dialysis session. The Doppler did show a fresh clot, and we went in with an 018 system, and we used the Cat6 to aspirate the clot, and then we used an 018 balloon to angioplasty, and we've managed to get the flow back. So it's essential that not only do you remove the clot, but you also manage the underlying cause. So the keynotes are, in an ideal world, prevention is much, much better than treating. It does reduce overall the probability of AVF dysfunction, or at least it prolongs the period and the life of the AVF before they get these recurrent stenosis or recurrent thrombosis. If we can in any way reduce the trauma by using atraumatic technology, that's fantastic, and I think that's where the Indigo system fits in. Removing the majority of the clot, reducing that inflammatory cascade, again, will reduce that neointimal hyperplasia, and this again would fit in with the highest aspirating catheter being the Cat-D in this algorithm. I would also recommend adequate maintenance or follow-up monitoring system. It depends on staffing level, facilities, but if you want an efficient AVF service, I would definitely recommend good monitoring, whether it's the help of your dialysis nurses, keep an eye on the dialysis pressures, or by you reviewing patients with Doppler ultrasound. Whatever works best for your team and your patient is highly recommended. Well, thank you very much for your time, and we will move on to Neil's presentation.
Thanks, Bella. Sorry for my internet connection if it's a bit staccato. So I'd like to introduce Neil, who's a colleague of mine in Coventry, University College Coventry Hospital, and Warwick. So Neil did a fellowship in Australia for about a year, I think. Came back and took up a consultant post. So Neil, welcome. That was quiet.
Hi, my name is Neil Gupta. I'm an IR consultant at University Hospital Coventry, and I'm going to talk to you about restoring flow in an AV fistula. I have a disclosure, which is I'm sponsored by Penumbra for this talk. So I joined UHW in 2017, and there was no fistula thrombectomy service at that stage. In the preceding year, there was 50 thrombosed fistulas, only 3 of which went to theatre, and only 1 of which was successful, which I thought was pretty appalling. Previous experience for me was with AngioJet, which I'd used throughout my training, and I was quite comfortable with that system. But I attended the BSIR ASM in 2017, and I discovered the Penumbra India system. I was attracted to it for its use in stroke thrombectomy, which is what it was originally designed for, and the fact that it didn't use TPA. I also liked the idea that the angled catheter enabled you to try and scoop out more clot from aneurysmal sections of fistula, as opposed to the traditional systems which were normally over the wire. The over-wire systems tend to form a channel through the fistula and not remove the clot around the edges. And whilst that does work, clearly, I like the idea of trying to remove a majority of the clot so you don't end up with any propagation. So I set up this service at UHW with the full support of the nephrologists. In fact, they would bit my arm off to try and salvage some more of these fistulas. And the first patient we had was on the 1st of March 2018. The catchment area for our service is about 400 patients, and they are identified either on the main site or at the satellite units and referred to the on-call nephrologist at UHW. They arrange admission, bloods, and a duplex scan, and then they usually send an email to us to inform us that there's a potential patient, just for list planning and things like that. The case is then discussed between an IR and the fistula surgeons, and this is just to try and understand the best salvage option, open versus percutaneous. Often these patients are well known to the service, so either to an IR or to the fistula surgeon. They may well have already had recent fistuloplasty or even a thrombectomy previously, so we can then discuss whether another radiological thrombectomy is worthwhile or whether there's something intrinsic wrong that needs a surgical revision. And once thrombosis is confirmed on duplex, we then book it onto an IR list. We aim to perform the procedure in 7 days, although Penumbra says that you can go up to about 14 days. I tend to like to do it as quickly as possible, and my non-arbitrary cutoff is 7 days, but we would go over that if necessary, but we've managed to do all of ours within 6 days so far. The Penumbra comes with a range of catheters, and the Cat 3 was the one that originally designed to go up into the MCA and the brain, but the one on the other side of the picture is the Cat D, which is the one that's designed for fistulas, and this is a short shaft 50 centimeter catheter with an 8 French lumen, and that enables a good amount of clot aspiration. The Cat D can also be used as a slightly longer shaft, either an 85 or 115, if you need to get that extra length. In essence, it's a big tube that you stick a sucker on the end and suck, but it is a very large intralumen, as opposed to obviously being the size of an 035 wire. What it also comes with is this separator device, which is basically a wire with what I call an olive on the end. And the olive is about 85% occlusive to the catheter lumen. And so as you push it in and out of the tip of the catheter, it enables you to draw clot into the catheter and then allow that suction to aspirate that clot out. In essence, you could just stick a syringe on the end of the catheter, but what happens is your aspiration vacuum will very quickly full, and so the Penumbra engine, or the Penumbra system, allows that continuous aspiration pressure to continually draw clot up and out the catheter. It can be quite alarming when you get into free flow, because the aspiration power is quite impressive, particularly on the Cat D, and you're talking about 200 mils every 20 seconds, so about 10 mils every second. So when you get into free flow, you know about it, because it just starts hosing out the back of the catheter, and you can exsanguinate the patient pretty quick. So you just need to be on it when you're using the system. I always get a duplex scan for all thrombosed fistulas, and that's because I love my nephrologists dearly, but I do want to be 100% sure that there is a thrombosed fistula, and not just a low flow or one that's difficult to palpate, because you don't want to plan for a 2-hour thrombectomy procedure if actually it's not clotted at all, and it could just manage with a quick fistuloplasty if the central chronic artery or something is slightly stenosed. In addition, at my unit, not all of us do fistula thrombectomy, so you don't want to be saying, well, it needs to wait till Thursday when Neil's back, when actually a simple fistuloplasty would do, and any of the IRs can do that. It also gives you a huge amount of information about how to attack the case. It will tell you how much clot is there, so if it's a short segment occlusion, if the entire thing has gone down, where you need to puncture, so if it's going to be 1 or 2 sheaths, and I'll come on to that in a minute, and if there's any aneurysmal segments, again, to understand the clot burden, and what's the arterial flow rate like. So sometimes there might be an underlying inherent problem with the arterial inflow, and therefore you think, well, is this really going to be a salvageable fistula? And again, coming back to the idea of whether this is whether this needs a surgical option or not. So the picture on the left is what you want to see. This is a kind of a lovely short segment occlusion with a patent stump of fistula before it then occludes, and then you've got an underfilled outflow vessel. And it means you can just pop the sheath in that stump region, that patent stump. You can then pop the indigo or aspiration catheter straight in onto that clot and start sucking. Once it's cleared, you can then pass a wire straight up, plasty it, and then do a fistulogram all through that single sheath with inline flow. And this is what you see. So you've got that sheath in the elbow in this instance. You've got that occluded segment with the patent segment higher up. You suck it out, plasty it out, and you then end up establishing flow. And the reason that you get this this appearance is because if you look at the picture on the left, after a short distance on this patient, you've got a little collateral that flows off to the right, to the left of the patient. So sometimes you don't like this appearance because it's taking away blood flow from the main fistula, but it does protect that fistula when it thromboses, because it doesn't then thrombose and propagate all the way back to the anastomosis. And this patient demonstrates the necessity, or the benefit of fistuloplasty being done in a timely fashion. So the picture on the left was done on the 12th of February, and by the 17th of February, this fistula has clotted, but it hasn't fortunately clotted all the way back to anastomosis, and it means you can then, as I say, pop the fistula into that, pop the sheath into that patent segment, clear it out, and get it going. And this is the bit where I say that I actually haven't got very many pictures of fistula thrombectomy, because I do mine pretty much under ultrasound guidance, where once you've got the sheath in, which is under ultrasound guidance, I then remove all the clot under ultrasound guidance, and the only bit I then use for angiography for is the ballooning and the grams at the end. So this looks like, well, at the end, goodness knows what it looked like at the beginning. So the picture on the right is what we normally see. So these cases are where it's clotted all the way from the cephalic arch all the way back to anastomosis, and this is the mainstay. This is what generally happens. It's a larger volume of clot. It's going to take you a little bit longer to do these cases, and you've got two attack options, from the neck and from the two crushing sheaths. And this is what I mean by the two crushing sheaths method. And this is the method that we originally started using in our cases. And obviously, you pointing one sheath down towards anastomosis to then clear out the clot from that segment. And then you need another sheath pointing in the opposite direction to then clear out the outflow. And we did all our cases like this when we started out. We did our first 5 cases as dual operator. Myself and Susan Chaffee did all the first 5 cases together. But I didn't like, after about a year, I moved away from using this. I didn't like the idea, if you look at the bottom right picture, of that clot around that sheath. I never felt that you get complete clearance around the sheaths just because of the position of them. And also, I didn't like when you're pressing on it, sometimes you can cause a little bit of obliteration of flow. And I like the idea of coming from the neck and clearing out the clot in a different way. So after about a year, I moved away from this technique, but Susan Jaffe stayed with this technique, and actually our outcomes have been the same. So I don't think there's any benefit from one or the other, but I did go to this method of coming from the neck, the jugular puncture, and then getting a catheter round and back down the fistula. If you're really lucky, you'll get down without any help back into the fistula, but it's very difficult, and more often than not, I'll have to puncture the fistula with a micro puncture needle and then a micro wire. And I pass the micro wire up to the subclavian, and that gives me a landmark. And majority of times, I can then get down using the landmark of the micro wire to then get down with a Terumo and catheter down to anastomosis. It's actually only once I've actually had to snare the micro wire from the neck and then railroad them to go back down it. But most of the time, the wire itself acts as an adjunct to be able to negotiate back down. Once you get that down to anastomosis, I put them to go all the way right down to anastomosis and just start sucking. And in essence, you're using the aspiration to suck, and you're pulling it back. And again, I've got the ultrasound on there, and I'm visualizing that anastomosis, so I'm not going into the artery side, and I'm sucking as I'm coming back with the ultrasound and showing what I'm doing with the ultrasound and trawling back through the fistula. And as soon as you've cleared that plug of clot, you then get free flow, because the arterial inflow will then to clear that, and you then get a stump of patent fistula. You need to keep trawling back and just keep doing that all the way through until all the clots are removed. Once all the clots removed from the fistula, then pass a balloon all the way back down to the stenosis. And I normally choose a 6mm by 2cm balloon, and I trawl that through the fistula. And normally that will get snagged on the culprit, so the underlying stenosis. And then I know where to then plasty to ensure a good flow. And you get these lovely pictures at the end. This is a graft, which is why it looks so nice. Which then you clear it, and obviously this is the neck puncture with the 9 French sheet or the 8 French sheet popping down round, back down that subclavian. So the story so far. So we, as I said, we established this service in 2018 March, and it coincided with the establishment of a fistula MET, which was a meeting between the nephrologists, the fistula surgeons, the dialysis nurses, the IRs, and admin support. And all of those people are really important. And as I said, in the 12 months prior to this, we had 50 thrombosed fistulas. But in the subsequent 12 months after the MDT was set up and the thrombectomy service, we only had 25 in that financial year. So we dramatically decreased the number of thrombosed fistulas. And in the subsequent years, so the financial year just gone, we only had 20 thrombosed fistulas. And we directly correlate this to the establishment of the fistula MDT. So just giving the unit more license to be more aggressive with fistuloplasty, be more responsive, picking up patients with problems with their fistulas and presenting them with MDTs and getting them into timely fistuloplasty. And being more proactive with regular fistuloplasties for high-risk patients. So, for example, with patients with loop grafts, we bring them back very, very regularly, because often those are patients with not many more options left. And certainly with patients who've had a thrombectomy, we'll bring them back and aggressively monitor them as well with fistulograms, as opposed to just relying on duplex. And it's also lowered our threshold for cephalic arch stenting. So in the past, we were always very reluctant as IRs to put stents in, but having the kind of backup of the surgeons and nephrologists, knowing the implications of these patients' fistulas going down, we've been much more aggressive with cephalic arch stenting and getting really good results with that, particularly if you've got a thrombectomy case where it's gone down because of a cephalic arch problem. We've got very low threshold for stenting that, because it's only going to go down again. Cost of the service. So fistulas are a lifeline. These are, the patient's lifeline, and they really need to be maintained as long as possible. There is clearly a limit to the number of fistulas a patient can have. Most patients have only got 2 arms, and then you're down to legs, and then you really start to think things like heroes and things. But you really want to be trying to maintain fistulas for as long as you can, because the implications of them going down mean that they end up needing to have a line, which obviously has inherent risks as well as cost. And then subsequent to that, they'll need to be worked up for another fistula creation, which also obviously has risk and incurs cost. So the cost of a fistula thrombectomy service is negligible compared to the potential costs of these alternatives. And ultimately in the UK, particularly, we receive a higher income for dialysis sessions with patients on a fistula compared to those on a line. So the tariff for dialysis sessions is about £120 on a fistula, on a line, sorry. You get £160 if you have a fistula. So there's an incentive for patients to be given to have fistulas and dialyzed through fistulas, because they are better. And so there's an incentive, a financial incentive for the trust to ensure that patients have fistulas. So it's about £40 more per session, which equates to about £120 a week, so £6,000 a year per patient, as an increase to what you would normally get. So in our population of 400 patients, we're talking about £2.5 million more per annum if you've got patients on fistulas over lines. So it's really important, and keeping fistulas going for as long as possible is helps you with financially to keep your service going as well. So our results so far. So in our first financial year, we did 20 fistula thrombectomies, 11 of which were still patent at a month. In 2019, we did, so 1920 we got a bit better. We did slightly less at 15 cases, but 10 of which were patent, so 66%. And this year we've done 15 so far, so we're probably on track to do about 20, I guess, in the financial year. and 11 of which were still patent, so it's slightly improved again. So that's not bad, really, considering fistula thrombectomy is not normally can not be very particularly effective in some circumstances. So trying getting these patients clear at 6-7% is pretty good. It does take time. We started off taking about just under 2 hours on average time, but one of the cases took up over 3 hours. In the second year, we got a little bit quicker, 1.5 hours, and in the third year, it's about 1 hour 45 as an average. But as I said to you, those cases where it's a short segment occlusion, you can do in just under an hour, but the kind of classic cases normally taking about 2 hours, and the really tricky ones that are really stenotic and lots of underlying problems that might need stenting, those ones are going to take a good 2.5 hours or so. From a blood loss perspective, in the first few cases, we were losing quite a lot of blood, well, quite a lot, half a litre, yes, it's quite a lot, half a litre of blood, which was dramatic, but that's because of technique. And knowing you need to stop the flow when you get into free flow, and just having that communication when you're doing it. But these days we're very rarely losing any more than 250 mils, but more likely about 100 mils in a case, so very small amounts of blood loss. So I can't stress enough how much fistula NDT is important to running a service effectively, and particularly having a backup from these fistula thrombectomy cases, which would be very challenging. Always get an ultrasound, and that's to save yourself a lot of time and sanity. Aggressively follow up patients, bring them back for fistuloplasties and grams at least in 1 to 3 months, depending on how difficult the thrombectomy was. Have a low threshold for cephalic arch stenting. I think that's been a real learning point over the last few years, that's nearly always, or not always, but is often the case, that why fistula has gone down is the cephalic arch problem, and have a low threshold for stenting, it won't come back. And it's a 3-man job, or 3-person job, beg your pardon. You need somebody to hold the indigo catheter, wiggle the separator to try and get that clot drawing into the catheter, but you also need someone simultaneously holding the ultrasound so that you can see exactly what's happening and watch that clot being drawn into the catheter. And so whilst those 2 operators are watching the screen, you need someone else watching the penumbra system to be watching how much blood's coming out. And in essence, I always get it's normally the scrub nurse, and I get them to give me a running commentary, and so you hear them saying drip, 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 and then they say free flow, free flow, free flow, and that's an indicator that you need to either turn the tap off so you're not sucking anymore, or pull the catheter back a little bit more to get into another clot. Ultimately, you will often see that on the screen, but sometimes the catheter has got clot in it, and you don't see that free flow coming out very easily. So to have someone shouting at you in the background is very helpful. Having a measured volume of saline on the trolley is very helpful as well. So if you ever do need to clear the catheter out, you aspirate it from the saline, and it's recorded volumes. I normally put about 250 mils on the table, and it means that when you're sucking that out, you know that that's not blood loss in essence. So I think fistula thrombectomy is a really important procedure, and it can be incredibly satisfying. And as I said, you're trying to keep this lifeline going for these patients, and they will be eternally grateful. Thanks for listening. Look forward to answering questions.
Brilliant, Neil. That's fantastic. I've been reading all through the questions, and thanks. But I think there's some very interesting threads coming through. So I want to sort of start probably at the beginning, and these questions are for both of you just to discuss. So first of all is timing of when you would intervene. So obviously if you can intervene immediately, that's better. But what happens if you have to leave it overnight? How would you manage the patient?
So we as you say, we do it as quickly as possible, but we wouldn't do it overnight. Absolutely not. And you nearly always know when the clots happened in these cases, because obviously they dialyze 3 times a week. So they'll fail to dialyze on, let's say, a Thursday, and they'll call you on the Friday. And we would actually leave these until the following week. We wouldn't these out of hours. So you'd plan it for the Monday or even the Tuesday, but we wouldn't want to go above 6 or 7 days. That tends to be our intrinsic cut-off. We want to do it within a reasonable time frame. Obviously, the fistulas that go down that are non-dialysis fistulas, they're pre-dialysis fistulas, they're a bit more tricky because you don't know when they've gone down, and often those are not ones you want to be starting to get into. So 7 days is our cutoff.
Bella?
Same. I would even narrow it down to 3 days max. It depends on the service setup. I wouldn't do it overnight. There's no necessary indication unless, you're private and you want to do it overnight. But certainly as an NHS service, you wouldn't do it overnight. Try and do it the following day if your team and your setup would allow. So if it comes in on a Friday evening, it can wait till Monday. It's not ideal. But I think if you can do everything within 24 to 48 hours, it just means the clot is fresh. And with any device, irrespective of indigo, the fresher the clot, the easier your procedure will be. And as Neil pointed out, the more tricky the fistula is and the anatomy and the setup and the clot, the longer the procedure time is going to be. So if you can try and get it while it's fresh, you're going to cut your time considerably.
So I think you've 2 points there. A lot of them are acute on chronic systems, aren't they? So obviously you've got to deal with the chronic aspect, probably with the balloon. And so the question really is, if you've got to wait over a weekend, would you recommend heparin? And if so, how?
We don't. We send them home and they come back for their procedure.
Okay.
If they're well. Obviously, unwell patients is a different thing. The renal team may admit them, but I'm talking about just your average acute thrombosed fistula patients, especially the ones they're your familiar cases. They have long-standing stenosis. They will go home and then come in for the day for their procedure.
And you're right, there's a question about potassium levels, and exactly that. The nephrologists will obviously be monitoring them, and that gives you an indicator at the baseline of how urgent this needs to be done. So if they're creeping up, and you think, well, and the nephrologist is telling you this patient's going to have a line, you think, well, we just need to get it in because we want to prevent having to have a line insertion. So that's often a key indicator to say, let's just get this done now. Whereas if potassium's completely bond or normal, you can wait a few days.
So with that,
and we don't tend to put lines.
So first of all, the jugular approach, I think, is a really good way of approaching both the arterial and the venous side in an easy way. However, the angulation sometimes from the left and the right can be tricky. So that's one question. Have you had any problems? And the second question on your point of potassium is obviously when you're putting wires in the central veins, there is a potential to go towards the heart. But generally speaking, patients who dialyze are quite resistant to high potassiums and arrhythmias.
Absolutely. That's the key thing. As long as you're not using a mechanical, basically something like the angiojet, that I wouldn't use, but obviously that's on IFU. You shouldn't be using it with high potassium levels. But in the indigo, it's a lot safer because it's an aspiration. It's like putting any catheter in any other patient. It doesn't macerate. It doesn't interfere with the rhythm. And in terms of the jugular approach, absolutely love it. And I think since I've been doing it, most of my procedures are jugular, unless for any particular reason the clot is there or it's stenotic or doesn't exist. And it's a learning curve. The more you do, the more you get better at it, the more you know what kit will work for you. So it's just a learning curve to get your head around rather than, avoid it or only use it in selected cases.
And has COVID changed your way of approaching these, given the fact that obviously if you're accessing through the neck, you're quite near the head?
I mean, I think we're next to our patients for all sorts of cases, so it shouldn't really affect as long as you've got the protection.
No, you shouldn't change the technique based on COVID. You should do what's best for the patient. So yeah, I've not changed my technique. That's the best technique for me, and it works.
And what about TPA?
So the point of the system is its aspiration, and yeah, if you get there quick enough, you shouldn't need to use it. I will admit I have used it on 2 occasions. And those were exactly the cases that you were alluding to. So the ones that we left over the weekend, I think they went down on the Wednesday or the Thursday, and we weren't able to provide it on the Friday. So it waited till it was Tuesday when I was next back in because I don't work Mondays. So that was 6 days, and it was acute on chronic. It was a dodgy fistula. There were so many things about it that weren't great. And then I wasn't gaining any traction with the aspiration thrombectomy, so I did then lace it with TPA. just with a multi-sidal full French catheter, left it for 20 minutes, went for a cup of tea, came back and then sucked it out, and it was fine. It worked perfectly. But it's very, very rare that you ever need to use TPA. And it's, as Bella says, if you get in there in 2 or 3 days, you're fine. If you're letting these cook for a lot longer than that, you will run into difficulties, and that's where you might need to crack open the TPA. But obviously we want to try and avoid that. That's the whole point of aspiration, is to not have to anticoagulate these patients.
I must admit, the ones that I've struggled with are the ones that have the big pseudoaneurysms and are very large fistulas. So you've got a large volume, and probably all of the devices just make a little hole down the middle.
So
you can't get the rest of it.
Absolutely correct. The case with the types of devices which are over the wire, particularly. But the point of this catheter with the angle on it is that you can get a much larger circumference, so you can rotate it into those aneurysmal segments. And the other thing I do is I can milk the fistula. So just as the surgeons would doing an embolectomy, they Fogarty it and they milk it. We do exactly the same thing. So you've got the penumbra indigo catheter in there with its angle, and you're basically squeezing the clot into the catheter, so you're getting it wedged in. And that's why the ultrasound is so fantastic, because you can visualize that clot and get the catheter angle in the right orientation to then push that stuff into it. So that's why I think this is better than an over the wire technique, where you're just, as you say, Ian, just forming a channel through the clot.
And you know, when you sometimes do these, obviously you're aiming to get a perfect fistula and get rid of all the clot. But in reality, a lot of the old fistulas, they all look a bit ropey, and you know there's going to be an underlying stenosis. So at what point do you decide that you've done enough clot clearance, now's the time to do the ballooning to try and restore flow, and then hopefully the clot will potentially sort itself out? And do you trawl? I know one of you's answered this.
So there will, in particularly aneurysmal fistulas, you will have a chronic component there, and you're not going to gain any joy from trying to get that chronic component out. So you can see on the ultrasound that it looks different, and you can certainly see when the indigo kind of gets into it, you can see it's never going to get it off the wall, and that's probably because it's been there forever or a long time. So getting that channel out, as you say, and then yes, I do. I put a small 6mm by 2 centimeter balloon at the anastomosis, and I trawl it through just to get a feel for what's left. And you'll see where it crimps at any stenosis points that needs a good plasty. But yeah, once you just need a good 6mm hole throughout the whole fistula, in my opinion. Bella?
Yeah, I agree. And I think what tends to happen is once it's chronic, it's actually no longer clot. I think it becomes fibrotic tissue and fibrotic change. And that's important to understand, because you're not going to pull fibrous material with just aspirating. And we know that from central access, when we're clearing lines or pulling lines, you see that thready material. That's what I think is happening when it's been there for some time. Personally, I do not macerate. I don't pull or push balloons. I identify the stenosis if I can see it prior to procedure with ultrasound, or during the fistulogram, or if it's a known patient to me that I know where their point is. I would just go there and treat. My favorite balloon that I tend to go to are the high pressure Dorados. They've served me well so far. But it's case per case. Some will need cutting balloons because it's so fibrotic. Some may actually have reached the end of the line and may need stenting, though I rarely stent, but some of them unfortunately will end up going there just to preserve that fistula.
So with that, I mean, I'm obviously the old boy here, so I'm brought up with different techniques, but I started off by trawling because I saw a guy that just literally put a balloon in and trawled the whole clot and just deposited it where God sends clots, and then would actually use a needle to get the fistula from the outside to puncture and actually do a cutting balloon from percutaneously. I think you're right. I think that the high pressure balloon is a really good thing, and if that doesn't work, then a cutting balloon. Would you use one, both, or together?
Depends on how bad it is. So my regular customers, after a while, they reach that stage where I know the Dorado alone is not going to do it. So you would need to use Dorado initially, any high pressure balloon, sorry, then a cutting balloon. Then I would follow with high pressure again, just to ensure that there isn't some weird recoil, and hope for the best. And if I find that they come back again after that, then that's the point where you consider, do I stent at this stage, given the fact that we've kind of stopped or eased off drug-coated technology,
or when something else new comes in?
So I don't use high pressure balloons actually. I just don't. I just use cutting balloons, and I find them to work very effectively. And I have a low threshold for using cephalic arch stenting if I know that's the underlying cause that's gone down. My surgeon's very supportive of cephalic arch stenting because they can't get to that location surgically, so they can patch right the way up to the axillary region, but they cannot do the cephalic arch. If it's got to the stage where a fistula is starting to go down, then we do have a lower threshold for doing cephalic arch stenting nowadays.
So it sounds basically.
And I think technology.
Sorry?
Sorry, I was just saying that technology has also improved over time. So we've got all these new stents like Rhapsody that's supposed to be designed for AVF stenosis. I've yet to use it, but it sounds promising that maybe rather than fearing stents because they may re-stenose or occlude, and then what do you do after a stent? And that area, like you said, Neil, you can't operate on them. Well, you can't officially anyway. So fingers crossed, maybe the new technology will be helpful in future.
But it's a stage, isn't it? I mean, you would balloon, and if you haven't got, your balloon forming and you've got a stenosis, you'll just go up and up until such time as basically you hit an end point. Now,
and I think the old-fashioned teaching was that you wouldn't. I can't remember which way around it was because I ignore it. But they used to say, "Don't cut if you'd high pressured," or "Don't high pressure if you cut." I think it's all nonsense. I think you do what you need to do to get the thing running.
Yeah, no, I agree with that. And the worst case scenario is you make a big hole and you're going to put a stent in. So
exactly, you just put a covered stent in.
It's not an issue. And the other thing is, do you have a minimum size you think you should balloon the venous part of the fistula to get it working? You said 6. I'm old. I say 8.
6 around the anastomosis and 8 at the heart.
Yeah, anastomosis.
Because it depends on if you've got an old lady who's got a tiny, fragile fistula, you won't be able to get those sizes. So I do have some ladies who the maximum is a 5mm 018 balloon.
And a radial,
so I think it depends.
Well.
Yeah, in an ideal world, yeah, the bigger the better.
I'm not talking about the anastomosis, just the fistula bit. So I use an 8 on everyone. 6 French, 8 French.
Very brave.
8 on everyone. Have done for 20 years. Question though, I mean, stenting the cephalic arch, I think there's a lot of logic to that. It makes sense. You're nowhere near puncturing. And actually, that can be a difficult area for a number of reasons, just because of the fascia and stuff. What about when you have to put a stent in the fistula part where you might be accessing it? Does that concern you? Would it not concern you? If you do it, do you tattoo it? Do you not care?
I don't think I've ever put a stent into a fistula other than in the cephalic arch. I absolutely would. Yeah. The absolute last resort. Only if it ruptures and doesn't.
I'd rather they operate. Yeah, I'd rather a surgeon operated on that than for me to put a stent in there.
Yeah. Avoid at all costs.
Well, there was a young man called Dr. Riley who put quite a few stents in fistulas and tattooed them. He was quite a good tattooist at the end of it. And there's a guy in Dallas who used to put stents in, bare stents in the fistula, and they used to puncture through them with apparently no issues. Now, I don't believe that 100%, but I do worry about surgery sometimes because there's a big risk you could lose the fistula. And even if you stent and have a problem, you can still have surgery, can't you? So I don't know the answer to that one. I think the jury's out, but I think you're right. Avoid it if you can, unless it's a bailout.
So I have seen plenty of stents put in them, and I think the key is to put the shortest stent you can possibly put in. And as you say, you've got to show the way you've put it. But if it's a rupture, which is normally what you're talking about, just put the tiniest, shortest little stent just to treat that problem. And then, as you say, tattoo it or something. But yeah, try and avoid it.
Now, one question from a young man from Sheffield has said about, do you worry about recurrent jugular access to do your fistulas when you know that potentially is a source of access when the fistula goes down?
No, it's a temporary access point. It's not going to cause an underlying stenosis for the short period of time that you're in there, in my opinion.
And it's done by an interventional radiologist with sound skills, so that's a big difference.
Yeah, we're puncturing it.
Most of the cases that I've done have been 2-3 years now, so they've not come back with issues relating to jugular. So it's just a quick, smooth, swift jugular puncture, and then I don't suture. I don't do anything. It's pressure, elevation of a patient up on the bed, manual pressure on the neck, and you're done. There's nothing further. In fact, when they come back, I can't even see where I'd punctured before.
Yeah, that's because you're an interventional radiologist. One question then about the arterial anastomosis, because I think the venous stuff to some degree is relatively straightforward and you're not so scared about it. But when you get to arterial anastomosis, I agree with Neil, really, 6 is probably the maximum. But at what stage would you not balloon it? So if you've got a new fistula, would you worry about the age? If you're having to balloon it, do you worry about going into the artery? And if you do you like to go upstream or downstream? Do you worry about emboli? Do you use heparin?
I use heparin and GTN. I use 018 or 014 system, and I go via jugular approach round into the arterial system. But I do balloon it. I don't have fear. If I've got the indigo, I've got indigo. I'm aspirating. Should anything, touch wood, go anywhere. Neil, I don't know about you. Do you?
Yeah, I put the ultrasound on the anastomosis, bring the indigo right down to the anastomosis, and then you start sucking. So you're basically just pulling in the arterial flow into the fistula. So there's no real risk. Well, there is obviously a risk, but as long as you're doing it carefully under ultrasound, you're not pushing that fistula in any further. You're doing it under guidance and just pulling the fistula out back into the fistula, so to speak, up in indigo. So I've not had any arterial emboli cases.
And in terms of rupture, so obviously Bella just described the venous anastomosis from the jugular going around the anastomosis and back up to the brachial. Do you think there's an advantage with that? Because if you rupture the arterial anastomosis, you could put a covered stent and actually maintain inflow, just losing obviously your radial, or what do you think?
I've never seen an anastomotic rupture.
Come to UHB.
But the problem, I guess you could argue, with the indigo system is you don't have a wire across when you're aspirating. So like angiojet, I know we use that as a classic example. It's a good comparison.
Not the system, not the aspiration. It's when you have you've ballooned it to clear it. You've done your thrombectomy, but you've got an anastomotic stricture that you're ballooning. That's
right. Sorry, yeah. Yes, you want the wire to go back up the artery. Yeah, I've never ruptured an anastomosis yet.
You should have more registrars.
I've not seen stenting of the anastomosis from the arterial to the venous side before.
So about 14, 15 years ago, I did have someone who used an 8 balloon and anastomosis, not realizing it was only like a 5 millimeter vessel. Then lost access with the wire and then called. So that was a good case to deal with.
But yeah, sometimes you can't. Sometimes you can't get the wire to go up retrogradely, and you have to put it down to the downwards. But normally, once you've plastied it once, just with a 4 mil, that will be enough to then give you the torqueability to then flip it up. So I would always try at all costs to get it to go up for that reason. And you want the flow to be in line from the artery to the vein. So you do always want that line to be going up. But I've never thought about it from protecting it from a rupture perspective. But yeah, of course, that's a secondary benefit.
And a little bit of GTN helps if the patient can have it. A little bit of GTN definitely helps you when you're trying to fiddle around. And definitely a smaller system, 018, 014, if it's tricky, is very, very helpful.
Yeah, no, I agree. I think that's the perfect answer, really. I mean, I use a bit of papaverin rather than GTM, but I mean, it's just whatever drug you're comfortable with, to be honest with you. And of course, I'm old, so I never use a micro system. I just use big stuff. But I think you're right. I think the important thing is probably to use the equipment you are comfortable with and used to, and you know that you know how to use it. And I think that's probably true of all intervention, to be honest with you. It doesn't really matter what necessarily you use, it's just what you're used to and you know works. I'm not too sure we've got any more questions. What do you do then with a recurrent fistula that goes down. So you've got month 1, you've done it, then it all looks good, you've treated it. I think one of you said you wouldn't heparinize after you've done a trawl and a balloon. So that'd be an interesting comment. And then the second thing is, if it goes down, say within 3-4 weeks, would you retry? If it goes down within 3 months, would you retry? At what point would you say it's dead and buried?
There's just not an answer that fits all, because every fistula is so completely different, and every underlying cause is so completely different. And it really does depend on what the underlying cause was. So sometimes you just got a dodgy anastomosis that's just kinked a bit, or it's all a bit fluffy, and you suck it out all first and then go, oh, that was the underlying cause. And when it goes down again, you think, yeah, this needs a surgical revision at anastomosis. If it's a cephalic arch problem, as I alluded to before, our surgeons don't really like the cephalic arch or going into that kind of territory. So often they will then say, well, please, can you suck it out again and then put a cephalic arch stent if you haven't in the first sitting. And if it's these, we've had a couple of cases where they've just gone down, and we, again, as you say, 3 or 4 weeks, so it comes back again, we've done it again, and then the third time it goes down, and you just think, yeah, what do we do surgically, or give up? But once you've exhausted those options, you're at the end of the line, aren't you?
I think the other thing is, as you say, I think you keep things simple and have a stepwise approach to matters, to try and not put a stent in if you can get away with it, knowing that if you put a stent in, you're probably going to re-intervene more frequently. And then once you've got past the stent, then, you know, when you've got no other option, apart from perhaps maybe doing the declot again to allow them to form another fistula to mature enough so you can basically, you know, not have to put multiple lines in. I don't know what your thoughts about maturation of fistulas and timing, but
yeah, I think that's exactly right, and it comes back to being a case-by-case basis and discussion with the surgeons and MDT to understand how this impacts on the patients. If you know they haven't got any other fistula options, you know, they've exhausted them on their however many fistula, that will give you a completely different set of cards than if you've got someone who's on their, you know, radiocephalic that could easily be swung up to the cephalic. So to the elbow, things like that. So I just don't think you can have a single answer for that question. I think it's all about MDT, surgical input, nephrology input, patient input, and understanding the entire holistic approach.
And do you think other devices on the market, of which I did look out, I've got the Cleaner, the Aspirex, the Jet-Eye, the Angiojet. So do you think there is an ideal thrombectomy device? Do you think that some might have advantages over others with specific fistulas? You know, like as we said, the big one with a clot burden that you can't get to the side. Or do you think it's more important to stick to one you know well and you understand?
Both. Yeah, there's an element of horses, of course. I think grafts probably respond better to the Angiojet, because you've got well, the Angiojet works really well with it, but because you've just got such a single 6mm tube all the way through, it's pretty rapid with the Angiojet, because it just goes in, you form that vortex, and you just go sucky. But Indigo works just as well. I think getting good with one system is important, because we haven't yet progressed on to doing arterial thrombectomy. The reason I flirted with Indigo originally was because we were looking at stroke thrombectomy, and I know, and as I said to you in my presentation, Indigo developed from stroke thrombectomy. So we were looking at getting our skill set up in fistulas to then use it in the peripheral arterial and the brain. We haven't progressed to that yet, but it's certainly something that's thought about.
My colleagues use Angiojet and they're happy with it. I personally don't like it. It's just, for me, it's cumbersome to set up and to use. But I think I agree with Neil. Grafts are a lot easier to remove clot from. It almost always, prosthetic grafts. So whatever device you use, it tends to work really well. The tricky bit is the complex fistulas with multifocal pathology, mixed chronic to acute with fibrotic. They're a challenge for whatever system you use. But obviously, gain experience with one kit, because I know that some people who've used the Angiojet for so many years probably will get good results as we do with the indigo. The only advantage that I see with the indigo is that it doesn't affect potassium levels or cardiac issues, which a lot of renal patients, they're fragile and they've got all sorts of things going on with them. So it saves you from that, and you can just go ahead and crack on and use it.
Yeah, no, I think it's always best to get used to one system that you understand before moving on to a second system. I think that the truth is probably the one system doesn't do everything. I think they've probably got, you know, some advantages and disadvantages between the different systems. Probably there's so many on the market with different theories means we haven't got an ideal device yet, or perhaps we've got too many different fistulas. I don't know. Someone did mention about the final run, do you include the pulmonary arteries? I think I know the answer to that one, but
best not to look, I guess.
It's an aspirating system, so technically there shouldn't be embolic material. And I think when they did the flow models, who are not real humans, the angiojet did flicker a lot into the pulmonary system, but the indigo didn't. But this is based on plastic models, not humans.
But as you alluded to, Ian, I'm a believer that the pulmonary arteries are there to filter low volume clot. You know, you're only worrying about big, massive iliofemoral DVT dislodging and giving you a massive saddle embolus. You're not worrying about these microemboli. They're completely normal. That's what the lungs are there for, to protect the brain from stroke. So,
and I think there was data as well from Dr. Chalmers in MRI a while back when he did all his balloon maceration cases, where obviously he'd macerate and throw into the pulmonary system. Well, none of those patients died with PE or anything. So it goes to show that this amount of clot from fistulas is not your classic DVT, large killer clots.
And I have seen with angiojet that you do get sometimes, actually quite rarely, a transient drop in SATs, but it very quickly comes back up, and it's just the body mechanism of anticoagulating itself and getting rid of those stuff. So I've never been worried about that.
I think the other thing is a lot of people with the old systems were using some degree of TPA, and you've got fresh clot, and fresh clot in the lungs will disappear quite well. It's when you've got that fibrin sheaths and lots of old fibrinous material that will cause a blockage. So I think you're right. I don't think you need to worry. I've certainly not had any problems in 20 years, so I don't really worry about it. I do worry when you've got those macro fistulas. I slightly get concerned about trawling with that, but I think that the indigo is a great system to sort of declot it to start with, and what you have to do afterwards, you know, is something secondary. I'm not too sure we need to. Some people have asked, have you any experience of using the indigo in other areas? So, for example, arterial, SMA, celiac axis, maybe even legs?
Yeah, it's very good for legs. I think that where indigo is actually elite is in ALI, acute lower limb ischemia. And in other countries like Italy, for example, the surgeons have moved away from Fogarty to using it. There's an Indian registry that should be published, or is published now, that shows it. But it's, if you can get fresh clot like a acute AF and they lodge it into the common femorals or in the SFA, it's fantastic. It works so much quicker and so much easier than
have you used it better in the PAD?
Yes, yeah, I've used it in the SMA, I've used it renals, and I've used it in lower limb. I think it actually does a lot better in lower limb, or when you trash the anterior tibial, for example. It's, as long as it's fresh clot. Obviously, if it's a calcium plaque, that's a different matter. As long as the plaque size can fit the catheter, it may be tricky otherwise.
I haven't developed yet into doing peripheral clot, but I would love to. And it's just, as with ever, you want to find the right case. And I remember there was a case on this, I think we set up our service on the 1st of March, and something like the 5th of March, there was an absolutely beautiful short popliteal occlusion, fresh clot, and it would have been a classic, perfect case. But I didn't have the personal confidence to do it at that stage. But I would now if we had a good case, but we haven't yet had a good arterial case.
I think you've both mentioned the most important bit is that if you have fresh clot, doesn't matter where it is, it sucks out very easily. It thrombolizes very easily. It's relatively more easy to manage, which is probably why the timing is quite critical. I mean, I think just to mention to the audience that we are going to have another webinar from Penumbra on acute limb ischemia, where I think some of these questions will be looked into in more detail. I mean, my worry is always that calcific plaque, that fibrinous bit that goes down, that, you know, is a nightmare to suck out with anything.
But I think if you're going down the line of catheter-directed thrombolysis and you've committed to that, then sticking the indigo down there first, just to try and get some of that fresh out, will obviously reduce your amount of CDT. So if, for example, you might have had to go to 2 days, you might get away with just one, and that has a massive impact on the trust in regard to beds and ECU and TPA and risk. So clearly just using it as an adjunct may be beneficial, but clearly it might work actually and clear it all out. You plasty it and you're home and dry, which would be amazing. But I personally haven't developed that yet, but I'm sure it will come over the next few years.
No, I agree with that. I think the cost
and it's direct visualization.
Yeah, the cost of catheter-directed thrombolysis is actually more to do with the HTU beds and the high care of nursing you need afterwards. Yeah. I mean, I know if you know over 75 female and for 3 days is the increased risk of hemorrhagic complications, but actually it's the nursing cost. If you can deal with it in one event, you know, down, treated, done, dusted, and actually maybe even home to keep people out of hospital with obviously COVID now, using day case facilities is probably going to be the most cost effective.
Absolutely, yeah.
Yeah. The only thing I would add to this webinar is that we do lack data. We lack a lot of data in fistula management and fistula salvage. It's very limited out there. So I think moving forward, whatever device or system you use, whatever technique, it's really crucial that us as IR community, we get that published so we have better understanding of what is good and in what cases and long-term patency rates.
Absolutely. And there's good evidence coming out with barn stenting, the cephalic arch. There's good evidence now coming out about drug-eluting balloons in fistulas. And we're looking to publish our data set. I think one of the questions is say, how's your patency after 1 month? Because I presented it on my side as 1 month. It actually doesn't tail off particularly. It does tail off a little bit. I'm trying to remember off the top of my head. It went from 67% to about 52, I think. Don't hold me to that. So it does tail off. But it comes back to what the underlying problem with that fistula was, and how effective we were identifying that, treating that, and following that up. And we've obviously just missed the boat with that. And to be blunt, sometimes it isn't our fault. Sometimes it's the patient doesn't want to come because there's nothing wrong with their fistula. And sometimes you do find that where you said you need a follow up in 3 months, and they said, well, why? Nothing wrong with my fistula. Because you just had it thrombectomized and it's got a cephalic arch stenosis, when you may not notice that clinically or from your dialysis, but I know that it's going to come back. So sometimes we miss the boat with those. Yeah,
a couple of young interventionists about 14, 15 years ago published about putting covered stents in central veins after spending probably 5 to 7 years putting in uncovered stents and then intervening every 2 months, and found that actually your patency rates were fantastic. And I think you shouldn't be scared of using stents. I think there is a role for them. You should use them when they're appropriate. But as you say, they're a bit like grafts. There is that silent stenosis and that silent thrombosis that happens. So they do need a little bit of care. And I actually think probably it's the role of the interventional radiologist to actually arrange some of that. And that's maybe the last question then, because Neil sort of mentioned it. I grew up doing fistulograms as a routine. And as we've got older, because of the numbers, we've moved to actually surveillance with ultrasound, which actually has been pretty good. I mean, led really by Rob Jones. But it is easier to follow up with ultrasound than doing formal fistograms with the current workloads. And what's your thoughts about, I mean, there are advantages and disadvantages. If you do a fistogram, see a stenosis then and there, you could technically treat it then and there and deal with it, obviously, but it's a large workload.
I think, I can't remember if it's Canada that are very vigilant with dialysis pressures. They monitor those, and they're usually the first indication that something isn't right. And I think moving forward, if we really want to reduce our numbers, if we can coordinate or collaborate somehow with dialysis teams and have a good recording of pressures and monitoring them, maybe we would capture problems fairly early on before they thrombose.
Absolutely. As I alluded to in my presentation, we went from having 50 thrombosed fistulas to 25 the following year, and that's purely because of the NDT. Because bringing these cases and saying the ultrasound says it's okay, but his pressures are horrific, he must have something wrong with him. So we'll just do a gram with the intention of treating the cephalic heart stenosis, because that's almost certainly what it is if it's high pressures, and if it's difficulty cannulation, it's an anastomotic problem. It's so obvious clinically what's wrong with these things, and when you feel them, you know what's wrong with it before you've even done a gram or an ultrasound. So I don't think I've ever performed an fistulogram. If a patient ends up on my table, I plasty it. Even if I don't see an obvious thing, there's something. It's got to be something. He's made us way to my IR room. I'm going to plasty that. And often you'll find a stenosis that you're not seeing particularly well. But the team is telling you this is prolonged bleeding. The patient's telling you it's prolonged bleeding. It feels as solid as anything. It's high pressure. It's got to have a cephalic heart stenosis, and it always has. So we're very aggressive with our fistuloplasty program. We've dramatically reduced our thrombectomies by that. And if the ultrasound doesn't pick it up, we go in and play. But yeah, it does put a lot of strain on your IR service, but it's worthwhile because you don't want to spend 2 or 3 hours doing a fistula thrombectomy when you can get away with a 15-minute plasty.
It's interesting you mentioned about dialysis pressures, because that data is actually freely available, and a lot of dialysis centres are actually remote, and actually the renal physicians can dial in and look at the pressures and see them just like you would look on your system for a blood result. And it's interesting that we don't have access to that, to actually sometimes have a system where we follow them up, because we would, I think, deal with it in a much better way rather than that delayed referral. So it is an interesting comment, and I totally agree with you. I think pressures and a hand is probably all you need. Okay, well, I think that's been brilliant. I think it's been a really good discussion. Thanks, both of you. Really good opinions. I would reiterate what Mo's just put in. Mo Hamadi's just put a comment that only you and I can see, but we don't have much data in IR, full stop, and it's probably our weakness, totally, to know we get good outcomes. We believe we get good outcomes, but we don't have data. So a big push for data, full stop, for IR. And obviously, in this area, certainly we need some more data. And it's just to say thanks to Neil and Bella. Thanks to Penumbra for sponsoring the webinar. Thanks to Scott and Ruth, who are hiding behind the scenes. And look forward to the next one. So thanks very much.
Thanks, Ian.
Thank you. Thank you, everyone, for joining.
Thank you. Yeah. Bye-bye.
Bye.